today we will be discussing the case presentation of hypernatremia. The baby was admitted in Himalayan Institute on day 13 of life with complaints of not accepting feed and having staring looks for 3 days and abnormal movements of all 4 limbs for 2 days. Next slide. So in obstetric, there was nothing significant available in obstetric history and the antenatal history. The events before which the admission to the HIMS was the baby born by the baby born by normal vaginal विजय जी थोड़ा पीछे विजय जी स्लो डाउन, ये फास्ट हो रहा है.
सर ये एनिमेशन में सपोर्ट नहीं कर रहा है विंडोज में. ओके हाँ, यस सर.
So the event before was the baby was born by vaginal delivery having weight of 3 kg and was discharged after the two days of life. Yeah, discharged after 2 days of life. On day 10, the baby had refusal of feed and staring look. On day 11, the baby had abnormal movement of whole limbs, for which the baby was admitted in outside hospital, and the treatment given was phenobarbital, calcium gluconate, injection vitamin K and FFP transfusion. And on day 13, the baby was brought to the HIMS. On admission, the baby had weight of 2100 grams with loss of 30% of weight. The baby was sick, dehydrated, and hypothermic, had pale color, and the CFT was deranged within 3 seconds of CFT. The heart rate was on the lower side of 106 per minute. PP was not recordable. PI was not recorded at that time. And respiratory rate was 42 per minute, with SpO2 could not be recorded, and RBS was high. Then next slide. On examination, on general examination, signs of dehydration with sunken eyes, dry oral mucosa, delayed skin change were present. Sclerema, first discharge from the umbilicus. Blanchable petechial rash over neck and bilateral shoulders, and right hand and forearm were present, and also depressed nasal bridge and tongue-tie was present. Can we move to next? In the genitalia were normal male genitalia with bilateral testes palpable. There were no hyperpigmentation or rash, and both bilateral upper and lower limbs and joints were normal with no limitation of any movement. Or there was no salmonella. There was no generalized exanthem or ulceration or desquamation of skin, and no ulceration or rash in oral mucosa also. Next slide, please. In its systemic examination, in CNS, the head circumference was greater than 10 percentile with 34.3 centimeters. There were overriding of sutures. Tritone activity all were decreased, with routine sucking were also absent, and the pupil were of bilateral mid-size and sluggish reacting. It shows that the baby's brain was in encephalic state with altered sensorium. Next slide. In respiratory examination, the chest shape was normal with poor respiratory efforts, and rest of the examination in respiratory was normal. So the respiration was also depressed. It could be because of encephalopathy or the use of phenobarbital in previous hospitalization. This was the X-ray, which was grossly normal. Next one. The abdomen was soft with mild distension, and altered respirate through the OG tube was present. Bowel sounds were present but were decreased, and the liver was just palpable with soft and was soft and had smooth margins. Next slide. There was nothing significant in the examination of cardiac examination. Next. For the kidneys were not palpable on deep palpation. Urine output was decreased with dark yellow color of the urine, and there was no sediments seen in gross examination. Bedside USG was done, which showed bilateral normal size of kidneys. In fundus examination, no signs of chorioretinitis were present. Next slide.
Hello.
Hello.
Dr. Shailendra,
Yeah.
yes, I'm sorry to interrupt you. I think that there are two devices that are unmuted near you. There's an echo coming. I think maybe you can just keep the audio on for one device and unmute the other one.
Okay.
Okay, thank you. You may continue. Sorry to interrupt.
Thank you. So based on our based on the complaints and the initial assessment, we made a provisional diagnosis of sepsis with meningitis with dehydration and coagulopathy. It could be diuretic abuse from the previous hospitalization, and other provisional diagnoses were congenital diabetes mellitus or intrauterine infections or IEM. So next slide, please. So keeping in mind of these provisional diagnoses, we went for the investigation. So we found in the blood test there was mixed acidosis with high anion gas. Next slide. And then we in the hemogram there was thrombocytopenia with increased TLC, and CRP was raised with value of 62, and coagulopathy was present. PT was deranged with 30.3 seconds, and INR was 2.33 seconds. For dehydration, we looked for the electrolytes, in which we found sodium was 178, severe hypernatremia was present. Potassium was also there, 8.62 value, millimole per liter was. Serum creatinine was 3.13 with urea of value of 262, which shows that there was dehydration was there. Serum osmolarity was also raised with value of 312 milliosmol per kg. It showed there was contraction in the intravascular volume. Urine osmolarity was increased of 510 milliosmol per kilogram. 2+ urine sugars were present, and 1+ ketone was present, which shows ketoacidosis in our baby. Another significant findings, CSF culture showed Acinetobacter. So we previous slide.
मेरे में एनिमेशन सपोर्ट नहीं कर रहा सर सही से.
Okay, next slide. Can we move to next slide? We did the ECG also, which showed only sinus bradycardia, and USG KUB and USG abdomen was done, which were essentially normal. And so the baby, and because the baby had a tongue tie and the depressed nasal bridge, so we did the karyotyping also, which was essentially which was found to be normal. To rule out, keep it here. To rule out IEMs, we did TMS, which was normal, and to rule out intrauterine infection, cross profile vision, which was normal. Next slide, please. So this was the ECG of the baby, which was showing only sinus bradycardia. Next, please. So we started after assessment, and started giving the treatment in form of mechanical ventilation was started, NS bolus followed by IV fluids and inotropes, vitamin K, IV antibiotics, phenobarbital in the maintenance dose, and next FFP transfusion was given. Next slide. FFP transfusion was given, and for hyperkalemia was managed by calcium gluconate and insulin, which got corrected over the next 6 hours. Next. So today we have gathered here to discuss mainly about the treatment of the hypernatremia. Other problems were managed according to the protocols. So for the treatment of hypernatremia, we till now know that there was a loss of 900 grams in blood. The total fluid deficit was 900 ml, and the sodium correction which we need is 33 milliequivalent per liter, which to be given over 3 days with the target of 10 to 12 milliequivalent per liter per day of correction. Next slide, please. So first we calculated using the Heraclean book, which showed the correction to be given on first day was 1.15 liter, which was too much. So we didn't go for according to the Heraclean formula. Next. So we did, first we went through our approach 1, in which we plan to give the total fluid deficit and sodium correction over 3 days, keeping the sodium concentration of IV fluid which we are giving 12 milliequivalent per liter below the serum sodium value. So next slide. So at admission, the sodium level was, serum sodium was 178. Next, we started with the IV fluid concentration of 166 milliequivalent per liter. So after 18 hours, the sodium concentration was still at 178. So we continued with this IVF sodium concentration of 166. At 26 hours, the sodium concentration was still high and in fact increased by the unit of 2 at 180. So next slide. So we went with the second approach, in which we gave the amount of IVF equals to 1.25 to 1.5 times of the maintenance fluid per day, and the sodium, which was concentration, this was given for the approximately first 24 hours was N by 2, and approximately for next 48 hours was N by 3 or N by 4. So at 26 hours, we had sodium concentration of 180. Next. So on 26 hours, we applied next category, our second approach, and gave N by 2 for approximately 26 hours, which brought down the sodium concentration to 166. So we changed the our sodium concentration to N by 3, for which we gave it for the next 36 hours. So sodium concentration was brought down to 158, and then we changed the our IV fluid sodium concentration to N by 4, which we gave it for 20 hours. So it was then brought down to sodium concentration was brought down and corrected to 146 milligrams per liter on day 5. So we had now corrected we got the correction of the hypernatremia by applying the second approach. So besides the hypernatremia correction and the treatment of the other comorbidities, the course which had the baby had in the Kumar Institute was, on day 1 we started the treatment. On day 8 the baby was brought down to NIV and inodrops were stopped. On day 9 CPAP was started. On day 10 room air was baby shifted to room air. On day 11 anti-epileptic drugs were stopped. On day 12 case Katori spoon feed and breastfeed was started. On day 14 the baby shifted to mother's side, and on day 22 the baby was discharged after completing the antibiotic course of 21 days. So this chart shows the improvement in the blood parameters, all the blood parameters of the baby. The only thing with the hemogram, there is not much improvement in the hemogram and from platelet counts, but still it was on the improving trend, and there was a little bit decrease in the hemoglobin level. So final diagnosis we made was the baby of term gestation with severe hypernatremia and severe dehydration, with hyperkalemia, with AKI, with sepsis, with coagulopathy, with shock and meningitis, with CSF culture positive for Acinetobacter. So at the time of discharge, what should we be counseling the parents of this baby? We advise them to give a good nutrition to the baby, as the baby had a prolonged course of illness and was acutely malnourished, and prevent dehydration, as the baby can have such dehydration episode in the future also, and watch for the seizure as the baby had meningitis, and monitor the head growth of the baby, and look for the achievement of the developmental milestones of the baby. For the kidney, as the kidney also was, kidney function was impaired and had acute kidney injury, the parents were advised to keep on the urine output and the color of the baby, and to provide the early developmental supportive care and the early stimulation by giving motor, sensory, and cognitive stimulation. So the mother was advised to give tactile stimulation by giving oil massages and the passive limb exercises and the physiotherapy of all the 4 limbs. The mother was advised to talk and sing to the baby, have eye contact with the baby. And for the early intervention for the kidneys, the parents were advised to monitor BP, avoid nephrotoxic drugs in future, maintain proper hydration of the baby all time, and the nutraceuticals were advised. And they were advised to avoid the over 45 of the feeds, because the over fortification can increase the osmolality load over the kidneys and could further damage the nephrons. Skin care for the baby was advised, that the baby had prolonged NICU admission care and had multiple pricks. So it was advised to maintain proper hygiene and the proper hydration of the skin, and to apply emollients to prevent any breakage in the skin barrier. So nutraceuticals like vitamin A, D, and omega-3 and PFA were advised. And if any problem the parents see in the baby, they were advised not to wait and to immediately visit the hospital as soon as possible. So as a physician also, we should keep few things in mind in the follow-up. We should assess for the hearing of the baby. We did the OE, which was bilaterally passed, and in follow-up, we can do para. For which we keep watch on the vision of the baby, which in hospital at the time of during the admission, it was normal. For the follow-up, it should be evaluated in follow-ups. In follow-up, we should keep watch on the neurodevelopmental assessment of the baby. We should keep a chart of head growth and MRI if needed. We should keep the general growth monitoring of the baby. And the very important part of the follow-up is to look for the normal kidney function of the baby. We should ask for the urine output and the color. We should, if needed, then we should go for the renal function test and USG-KUB. We should keep record of the BP in each visit. We should ask for any episode of hematuria, gross hematuria in the baby. And the baby is very much likely to have chronic kidney disease in the future. So we should be avoiding any drug which is nephrotoxic. And if suspected, we can see the markers of the chronic kidney disease like cystatin C, albuminuria, and glycosuria. And in each visit, we should strengthen the importance of developmental supportive care and nutrition. Next slide, please. So what we got to learn in through this case that a Heritian calculation does not apply well to the newborns, and if we go through with our first approach in which we kept the IV fluid concentration 12 micromilliequivalent per liter below the serum sodium level, and it is also very difficult to apply, and we need very frequent calculation. So what more consistent and desirable correction in serum sodium we got by keeping the sodium NS concentration at 0.3 to 0.45% in volumes of 1.25 to 1.5 times of the maintenance fluid to be given over 2 to 3 days. And there should be proper counseling and adequate follow-up should be done, and especially focusing on the brain and the kidney functions. So that's all for the today. Thank you. Over to Neha to teach the hypernatremia.